Good evening, everyone. I am pleased that we can begin the new year, which is still relatively new. One could almost still wish a happy new year with another webinar, namely on the topic of news from ASH. Professor Al-Ali was there in December and has kindly agreed to report to us about it this evening. As always, please feel free to ask questions in the chat below. And Rainer, would you now introduce Professor Al-Ali, and then we will simply get started. Good evening from my side as well. A brief introduction from Prof. Al-Ali. Good evening to you too. Professor Al-Ali is Senior Consultant at the University Hospital Halle in Wittenberg and Director of the Krankenwehr Cancer Center. As an expert, among other things, in the field of MPN diseases, she is involved in numerous research projects in this area. She is, among other things, a member of the German study group MPN and is closely networked with other experts nationally and internationally and speaks at various congresses. She also actively supports her network, and we are pleased to welcome you this evening. Professor Al-Ali, you have the floor. Yes, a very good evening from me as well to everyone. All the best for this relatively new year, which unfortunately has been somewhat turbulent politically, with the hope that health-wise and privately everything will go better. Thank you very much for the invitation, and I am really very pleased to discuss with all of you today what the last ASH has brought us and where the journey is actually heading in 2026 and beyond. Yes, for everyone, as you know, ASH is the largest hematology congress worldwide, and this year it took place in Orlando, and I would now like to share my slides. So, these are my conflicts of interest, and now I will start right away. What has ASH brought us? Let us begin with a supposedly simple question: diagnostics. If today there is a clinical suspicion of MPN, symptoms or blood values, it is anchored in all the guidelines that as a physician you first tick JAK2 for the laboratory. That means this sequential diagnostics. If JAK2 is negative because 2/3 of patients are JAK2 mutated, then one would determine carotid-killing and MPL afterwards. And the simple question is this still appropriate today with all the possibilities, namely the so-called NGS, where we have the possibility in one step from the beginning to determine at least the 3 so-called classical driver mutations, and why might it make sense to determine all 3 simultaneously and not always individually? Because we know, and this was shown by Mr. Heidel in a study presented at ASH from the GSGMPN and the MLL laboratory. Well done. It was shown based on very, very large patient numbers, almost 30,000 patients, that approximately 1.5% of affected individuals have more than one mutation, and the most common double variant found is JAK2 and MPL, followed by JAK2 and carotid-killing. But there were also a few patients who had carotid-killing plus MPL mutations simultaneously. Now the question is, yes, okay, what does this mean? It is interesting to know, but does it have any impact on the course of the disease? Does it have any impact on therapy? The answer is yes. Basically, if I carry a JAK2 mutation plus another driver mutation, carotid-killing or MPL simultaneously, this does have an impact on my disease, regardless of whether I have ET or myelofibrosis. Namely, the second smaller clone alongside JAK2 also determines or strongly influences the course of the disease, the prognosis, meaning patients who have JAK2 plus caroteculin have a better prognosis even than those who only carry caroteculin. And the same applies to the MPL-JAK2 combination. And we also know the therapy response, as it appears, also depends on whether I carry 2 mutations or only 1. Therefore, it makes sense to determine all driver mutations simultaneously from the beginning, and many laboratories already do this, but not always. So, second question, and with this I come directly to the individual entities. What will most likely change in therapy in the near future? Polycythemia vera, PV. Simple question. Will it soon be the case that we no longer perform phlebotomies, that we no longer need them? As you can see, I have brought you the WHO guidelines, and we know that regardless of whether one is a low-risk or high-risk patient, phlebotomy at the beginning is always an integral part of the entire therapy, plus 100 milligrams of aspirin per day. And then we decide based on age and the presence of thrombosis whether one is high or low risk. And the question is, do I need the phlebotomy? Why? Possibly because a hepcidin mimetic can replace phlebotomy. What is a hepcidin mimetic? It is a protein produced by our liver in response to inflammation or iron deficiency. And hepcidin then regulates my iron release and availability for red blood cells to produce new blood. If hepcidin is too high, one can imagine, I find the image very nicely done, that hepcidin simply blocks all possibilities of releasing and making iron available for the bone marrow to produce new cells, meaning iron can no longer be absorbed from the intestine. Iron that I carry in my body, in the liver, or in certain cells in the spleen is also trapped there, so that my bone marrow has less iron to produce red blood cells. This is our natural hepcidin in the body, and if I give a mimetic, meaning something comparable to the body, namely the drug rusfertide, which you surely all know, or most of you, there were also studies in Germany, this causes more hepcidin to be present in our body, and that iron is no longer so easily available in the bone marrow for erythrocyte production. Here's the data from the phase 3 registration study Verify were presented. And interestingly, in this study, the patients were randomized at the beginning, either from the start, rusfertide subcutaneously injected under the skin once per week, compared to placebo control. And very quickly, you can see it in the blue line. The patients who received rusfertide up to week 32 had a very rapid normalization of hematocrit, and very, very often they no longer needed phlebotomies, compared to the gray line, which represents the patients who received placebo. Then in this study, it was planned that at week 32, patients who had received placebo as subcutaneous therapy plus or minus regular PV therapy could then switch to rusfertide. As you can see, gray line, once they were switched at week 32 to rusfertide, exactly the same happened as we had already seen in the blue line with rusfertide, namely that hematocrit again normalized very quickly in most patients, below 45%, and of course what is also very important is how long. And here you can see that it also a sustained response regardless of whether I received risperidone from the beginning of the study or was switched from placebo to risperidone at week 32. These positive results of the registration study will lead to Takeda applying for approval soon. Interestingly, one would not expect from a substance that acts exactly like our biological epsidine that, for example, there would also be an improvement in symptoms. Nevertheless, it was observed that in certain patients there was an improvement in quality of life, and most likely this is because we know that with many phlebotomies, many symptoms iron deficiency frequently develops in many patients, and iron deficiency itself causes many symptoms comparable to those we know in polycythemia vera. And if one no longer has iron deficiency because I no longer receive phlebotomies, then I also feel better. That is interesting. Quite certain common side effects were local reactions at the injection site. There were also various side effects as with any medication, but overall it was well tolerated, and one can see that most patients remained in the study for a longer period. I will move on to ET. As you all know, in PV there have been many developments over the last 15 years. We saw the approval of Pegasus, speculated interferon alpha 2A last year, although availability was not there at the same time, but meanwhile it is available again. We have the approval of Besremi, Ropig interferon in PV, and we have ruxolitinib Jakabi second-line therapy. In ET, there has not really been much change in recent years. Still, this hydroxyurea therapy or anagrelide, which reduces platelets but otherwise does not really have any significant impact on the course of the disease. And then last year, with the approval of pegylated interferon alpha 2A, we have also received an immunotherapy for ET analogous to PV. But we all know interferon. We have already used it off-label for several decades. I would honestly say because we know it works. In many patients, it can lead to normalization of the blood count, and of course, over time, it can also minimize the allele burden of the JAK2 mutation. But you see here, this chart is the therapy recommendation from the German language Oncopedia guideline, and it is not that old. It's from 2023, and there you can see reading in small print at the bottom that pegylated interferon, that is Pegasus, is still off-label therapy. You can see how quickly guidelines change because that is no longer correct since Pegasus is now approved. But where is the journey hidden? Are there further options? As I said, first question, Ropig interferon, which we know as Besremi in PV. The approval was based on the PROUD PV and continuation PV studies, where we were really able to show that patients treated for years with Ropig interferon not only showed normalization of blood failures, but that the allele burden in approximately 20% of patients after 5 years can be below 1%. Although, to be fair, we still do not know what that means for the course of the disease. But we know very clearly that interferon therapy, in this case Ropig interferon Besremi, leads to fewer thrombosis and less progression into post-PV myelofibrosis, and that is, of course, a very important point. Now the question is, what about Ropig interferon in ET? And here at this ASH, one of my highlights is, of course, the Ropig ET study. Data that were presented for the first time by Kiladian. and when Germany contributed very quickly to the success of this study. The study recruited incredibly fast where patients with ET, either untreated or already having received other site reductions, were then treated with ROPIC ET. We started with 125 micrograms every 2 weeks. Then after 3 months, depending on tolerability and response, the dose could be increased at 3 months intervals up to 500 micrograms, and you can see the distribution. In summary, most patients either continued with 125 micrograms or increased up to 250 micrograms. Tolerability was very good, and you can see here in the curve how nicely the platelets drop very, very quickly and are almost normal already at month 6. And the primary endpoint of the study was not only normalization of the blood count at month 12, which occurred in 2/3 of the patients, but additionally, this had to last at least 3 months. Patients had to feel well, and patients were not allowed to suffer thrombosis or bleeding. And that was the case in almost half of the patients treated in this study. Interestingly, this hematologic response did not have much to do with the type of driver mutation, meaning patients with CAR mutation responded just as well as patients with a JAK2 mutation. This is the first time these data have been shown. That means we only have the hematologic response and do not yet know how the elite burden of CAR and JAK2 will develop over time. MPL, of course, was not shown because there were only few patients. I find that great. This will probably also lead to approval for remiferaps at the end of this year or beginning of next, and this another interferon will be able for the treatment of ET. But, and I say this, I have been in hematology for a long time, and I have not really experienced that many blockbusters in my career. For me personally, for example, the development of imatinib in chronic myeloid leukemia was such an enormous blockbuster. Then it took 10 years, and then came the studies of ruxolitinib Jakavi in myelofibrosis, which was also for me personally a blockbuster, because of course the quality of life of many patients could suddenly be improved. And from my perspective, this is how my third personal blockbuster, namely the development of antibodies in mutated CAR reticulin. The difference between CAR reticulin and JAK2 is that parts of mutated CAR reticulin are exposed on the surface of the cell. You can see it in the cartoon. Thus, the mutated CAR reticulin becomes visible and targetable mainly through the JAK-STAT pathway, but also on the platelet. And I can bind it with an antibody, and over time this leads to the death of these diseased cells. And this has also been shown in animal and laboratory models that this death of cells carrying the mutation truly occurs at the stem cell level. That this is not just laboratory cosmetics, but that it actually goes to the root cause of the disease. The antibody does not yet have a name. It is currently called Inca 033989. We always say Inca 89. And it was produced by Incyte, and the phase 1 study, actually 2 phase 1 studies were launched in the USA and for the rest of the world, and they are still active. And the first data in ET regarding safety and efficacy of this substance were shown at the European Congress in June, and at its ASH, an update on this study in patients with ET was presented. It is impressive, as I said. The antibody is extremely well tolerated. For me, this is also incredible exciting because we have almost no side effects. It is an infusion given every 2 weeks. What is exciting is that within 21 days, 21 that is 3 weeks, platelets in over 80% of patients normalize or drop very well to around 500 or 600. 21 days. The well-being of patients is excellent. For me, this is always like a phoenix rising from the ashes. So impressive. And here only patients were included who were truly extremely refractory, no longer responding to all standard therapies. And the carotid mutation decreases in almost all patients over time. This is, for example, one of my patients. Extremely refractory. She always has platelets between 2.5 to 3 millions. Thrombosis. Her therapies, hydroxyurea, interferon, anagrelide, even chemotherapy with RSC. Nothing worked. She felt extremely unwell and she receives the infusion. In this case, she had 2,500 milligrams every 2 weeks. I discontinued hydroxyurea in parallel. That was allowed in ET, and you see within these 4 weeks, between 7th of July and 22nd of August, how the platelets normalized, and at the same time, how the HB, the green line over time, improved as well. It is almost like a miracle, and it speaks for itself that now, on average, the patients have already been in the study for 1 year. Over 90% are still in the study, and this is a phase 1. The whole story then continued. Of course, we also have mutated carotid stem cells, not only in ET, but also in myelofibrosis. And the same study was also for patients with mutated carotid who also have myelofibrosis, either as monotherapy with the antibody alone in patients who had also received JAK inhibitors, who were refractory and had not responded well, or in combination with ruxolitinib. And here, and although myelofibrosis is a bit more difficult, the patients included had their myelofibrosis for a long time. Nevertheless, you see that almost 1/3 of the refractory and heavily treated patients show an enormous response regarding the spleen, but also HB, because we have the problem of anemia much more often in myelofibrosis than in ET, that there is also a very good response in almost half of the patients. Again, the same picture, over 80% of patients show a decrease in allele burden of mutated carotid. And as I said, the data seemed relatively new. The response was very good, and again, 85% of the patients who have now received therapy on average for 1 year are still in the study. As I said, it's so very promising, and I would also like to show you an example of one of my patients. This is primary myelofibrosis. Again, platelets almost at 1 million. He also had a combination of fedratinib plus hydroxyurea, spleen involvement, the mutation. He also had an additional TP53 mutation when we started. He has received the antibody at 750 milligrams IV every 2 weeks for 1.5 years now. And you can see again how quickly the platelets normalize, the green line hemoglobin rising so nicely, spleen decrease, it disappears, and after 48 weeks, pathology calls me after we performed a bone marrow biopsy for follow-up, asking whether we had perhaps mixed up the patient's bone marrow sample, because you see only healthy bone marrow. I said no, we did not mix. And we have now confirmed this result again after 1.5 years. And you see over time his caraticulin, which was originally at 4.5%, is now around 18, and this TP53 mutation has gone from 3% to only 10%. That means the allele burden is slowly decreasing, but the clinical picture and also the bone marrow. That's the clinical situation. I always say the patients know each other, they meet together. It is simply a joy for me as well. And then I also always know why one is a physician, despite all bureaucracy and stress. The question is, how will this tremendously positive development with mutated caraticulin continue? At the same time, in a parallel, there is a study examining whether a so-called bispecific antibody against mutated caraticulin can be used. The difference from the simple antibody is how specifically it binds. It not only binds mutated caraticulin but also activates our immune cells, the lymphocytes. That means it will have a double effect, directly like an antibody, but also the so-called lymphocytes, our own immune system, will be activated. There's a study from Johnson & Johnson currently running with these bispecific antibodies. But we do not yet have clinical data, but even more exciting is an upcoming study for patients who mainly do not respond to the simple antibody or who have more advanced disease. A bispecific antibody also from inside. The difference between these two antibodies from Johnson & Johnson and from inside is that the simple antibody, which I just showed you, and the bispecific antibody from Johnson & Johnson both bind at one end of mutated caraticulin, namely the so-called C-terminus. That is not wrong, that is fine. The only small problem is that we always speak of type 1, which are deletions, type 2 insertions, or combined insertion with deletion. There are the two different caraticulin mutations we see, and we know today that patients with type 1 respond faster, more easily, and need less antibody compared to type 2. Therefore, this clever idea from inside, why not make the specific antibodies bind at the other end, at the N-terminus? Because the N-terminus is the same whether I have type 1 or type 2. And summarizing for the year 2026, we have, as I said, the study with the antibody still going and where fewer slots are not available, which repeatedly closed. It is really extremely exciting, very fast what is happening. We now have over 200 patients in the two studies, the American one and the one from the rest of the world. The V-specific antibody from Johnson & Johnson is also ongoing. And as I said, soon the study will also start with the B-specific antibody from inside, where the N-terminus is bound, in contrast to the antibody from Johnson & Johnson, where the C-terminus is bound. We are all in this process of learning, and I believe for patients these are wonderful opportunities. Now, of course, the question is everything only mutated caraticulin, and what about a large proportion of ET, but also PV patients who have the JAK2 mutation, and that is after all more than 2/3 of MPN patients. There is something there as well. Not only interferon, not only JAK inhibitors, but the problem we have with our approved JAK inhibitors is that we bind or inhibit the entire JAK2 gene. And thus, we often have side effects such as anemia or thrombocytopenia. especially in patients with MF. A specific JAK2 inhibitor that only works against the mutated region is already in development, not only in the laboratory, but also already in a study that has started in the US and will soon start here as well. And at this ASH, this specific JAK2 selective inhibitor was also reported. Just for your understanding, the JAK2 mutation that we know, the V617F mutation, is in a specific part of the gene, the so-called pseudokinase domain. And if I then target this tyrosine kinase inhibitor, these are tablets and not an infusion, only against with specific mutated part of the JAK2 gene, then the idea is, as in the SCML, is to switch off this part without impairing the function of the main JAK2 gene. As I said, the study will start again in patients who do not respond to standard therapies, whether PV or ET or myelofibrosis. However, of course, this time specifically for the JAK2 mutation. Where was new, especially in myelofibrosis, we have at least in Europe 3 JAK inhibitors, ruxolitinib, fedratinib, and momelotinib, and in the US a 4th, pacritinib. The question, was there anything new? There were many different things, but nothing really groundbreaking. Perhaps briefly about the newest JAK inhibitor, momelotinib, which we mainly use first line or second line in patients who have anemia. There was again a small analysis from the approval studies, which I also find important, namely the dosing. As with ruxolitinib or Jakafi, we always need an adequate dosage of medication in order to achieve an effect on hemoglobin. This is an important message because what I often see in everyday practice is that patients unfortunately do not respond. The first thing, whether it is Jakafi, ruxolitinib, or momelotinib, or Miara, I frequently see the problem that patients are taking doses that are too low, sometimes for no clear reason. And what I often do is simply increase the dose, provided, of course, there is no tolerability issue. That means the dose should be given adequately according to tolerability in order to have the greatest possible chances of achieving a good response. What is interesting is that the good response after 6 months can also be associated with improved survival, both in first-line therapy and in second-line therapy. And I find that especially for patients who often have only a minimal spleen response, what is decisive is that a patient with myelofibrosis does not receive blood transfusions. That is absolutely crucial. Even a small spleen response plus no transfusions. These combinations under momelotinib or Miara is associated with improved survival. We know the same from Jakafi, ruxolitinib. So those were again a few points that are also important for everyday therapies. Now, in every other disease except MPN, we now always have combinations. In multiple myeloma, 4 drugs are standard in first line, and in myelofibrosis, we're still working with just 1 medication. Now, here too, a lot is happening. Although officially nothing has changed yet, but a great deal is going on, and the combination possibilities are always that our base is a JAK inhibitor, such as Jakafi, fedratinib, Inverse, or momelotinib, depending on the case, plus then a second substance. And there are 2 possibilities. Either I give the second substance from the beginning together with the JAK inhibitor, or I start with the JAK inhibitor alone, wait 3 to 6 months, look at the response and tolerability, and then use the so-called add-on strategy if necessary, and add a second substance. For me, with the current data, this add-on strategy is preferable because anyone who has had a JAK inhibitor knows that the first months are needed to find the right dose. And secondly, we still have patients from the approval studies of ruxolitinib 15 years ago who are doing well on JAK inhibitor monotherapy. And the question is always weighing the benefits and risks of combination therapy. We have several phase 3 studies with various combinations. I will not go into them now, since data have only been presented for one combination as a phase 3 approval, but we have very many combinations that are still at the beginning and where we all have to wait and see where the journey leads. A simple example, if I am transfusion dependent in myelofibrosis and constantly receive blood, and as I said, for me transfusion independence is a very, very important issue. Ideally, we should prevent it, but if it's present, we should convert it back into transfusion independence, because that is definitely not only very important for a person's well-being, but also for survival. And we have the so-called TGF-beta ligand trap family. We have luspatercept, which is already approved, called Reblozyl, for a related disease, myelodysplastic syndrome. And there are combination studies with momelotinib, but at the same time, we also have a second very exciting substance from this group called elritercept in combination with Jakavi ruxolitinib. And the difference between elritercept and luspatercept is that they bind to different receptors. That elritercept, in addition to red blood cell production, also improves platelet production, which can be advantageous especially for patients with MF who have low platelets, and that we only need to inject it subcutaneously every 4 weeks. Whereas luspatercept must be given every 3 weeks. As I said, we have to wait and see how this develops. We had just spoken about the so-called hepcidin mimetic in PV. Now, let us simply take the opposite, a medication that inhibits hepcidin in myelofibrosis. What happens then? Then iron is made available to the bone marrow. That means for patients who have anemia, I can use a specific antibody that binds and blocks hepcidin this time. This is an antibody. These are still early data, but a very exciting principle, and we simply have to wait. Also exciting is a combination of ruxolitinib with a substance that minimizes fibrosis and can also reverse it again, the so-called telomerase inhibitor imetelstat. The first studies were also presented here for patients who did not respond so well to monotherapy, and then imetelstat is given as an infusion every 3 weeks. It's also very well tolerated, also a substance that I like very much, and we have already completed the phase 3 study with this substance alone. What else is very exciting also? So-called PIM1 inhibitor, which intervenes in certain mechanism in the cell cycle and suppresses especially the so-called MYCN, which is really very aggressive, especially in refractory patients. And the first data were also presented in this ASH. Very exciting to see how many combination possibilities are ongoing at the least combination. Is what I mentioned earlier, the combination in phase 3 that has already been shown. Ruxolitinib plus the so-called BET inhibitor, all oral therapies, no chemotherapy, The problem with the BET inhibitors is that, as you see above, two further examples, ruxolitinib plus other BET inhibitors development has repeatedly been stopped for various reasons. For this phase 3 study, the only one currently available, it is the combination with ruxolitinib, and this BET inhibitor is called pelabresib. And these are not even the first data, but now the 2-year data. In summary, the combination is given from the beginning. We also actively enroll patients, and spleen response and symptoms are roughly doubled when looking at all patients. Tolerability of the combination is comparable to what we know from ruxolitinib alone. Only if one honestly looks at the 2-year data, one sees that after 2 years already, half of the patients in the combination arm have discontinued therapy. That is exactly what we also know from ruxolitinib monotherapy. And initially, there were certain safety concerns that several leukemia cases were observed with the combination. That has now been relativized over the 2 years. Nevertheless, we first have to see what becomes of this data and whether approval will come at all in the authorities in order to make sure everything is in the green. Have asked Novartis to conduct a similar study called Manifest 3, which will soon also start again in Europe. So, what is coming? In summary, in addition to the antibodies and specific antibodies, various combination studies are coming in all phases, whether I am untreated or at the beginning. Combination ruxolitinib plus a substance from the MDM2 inhibitor, naftamalin, very promising is add-on. We have, as I said, the Manifest 3 study examining the BET inhibitor pelabresib plus ruxolitinib again upfront from the beginning, but we have also transfusion dependence or only anemia, because the question is always, why should I always wait until the patient becomes transfusion dependent? Why not start immediately when anemia is present? This eltiripsid plus ruxolitinib are also with the P1M1 inhibitor for patients who are refractory, who no longer respond to standard JAK inhibitors. So much is happening. I believe that now for every patient we have to learn what is the best option for each individual patient. Briefly at the end, many patients have splenic vein thrombosis, and in about 1/3 of patients, blood counts are normal. And then the discussion always arises, yes, of course, do I now give cytoreduction, yes or no? What does it bring to the patient? I have no disease course. I only have a JAK2 mutation in the blood. The patient has normal blood counts and has a life-threatening thrombosis in the abdomen. For the first time, retrospective old data from the US were shown, possibly a very large collection of patient data, 757 patients. These courses were gathered, in summary, one can say, independent of the blood count. Cytoreduction, regardless of what, whether interferon or hydroxyurea or whatever, reduces by 1/3 the risk of having another thrombosis. And we have a very high recurrence rate for second and third thrombosis, which especially in the abdominal area can also be life-threatening. In those patients in whom splenic vein thrombosis were seen, we also know are patients with PV followed by ET and fewer MF. That means cytoreduction in splenic vein thrombosis are very clear. Yes, we are already doing it, but the discussion always arises. Should I do this? I have no blood count to follow. It is normal. It is not that serious, not. What we do with the few patients who unfortunately progress into leukemia, into acute leukemia. The results are not really very promising. You all know that in acute leukemia we have many substances, many medications, much has changed, and when one looks at transferring developments from de novo AML to MPN patients who progress into acute leukemia, one unfortunately sees that highly effective therapies in de novo AML do not really yield good results in MPN patients who progress to acute leukemia. That means for these few patients there is still much to be done to improve survival, and allogeneic stem cell transplantation remains a very important cornerstone for these patients. And regarding transplantation, the study from Germany was presented from Hamburg by Nikolaus Krüger. Many centers, including ours, participated. The question ruxolitinib, Jakafi alone, or ruxolitinib, and then if I have a donor, transplantation. 155 patients were planned for the study. The study began in 2016, and unfortunately only 87 patients could be enrolled. This again shows how problematic the topic of transplantation is, and that it is not so simple. These were of course younger patients. In summary, 3-year survival whether I receive only ruxolitinib or plus transplantation is the same. Only that, of course, if I am transplanted, I have fewer relapses, less progression. That is clear. Nevertheless, and I find it good that the problems associated with transplantation were also shown, that chronic graft versus host disease can occur in 2/3 of patients. In every second patient, a severe side effects occurs, including infections, cytopenias, or GVHD compared to 30% with ruxolitinib. It remains important to summarize, transplantation remains a curative option. However, we must very carefully inform and select suitable patients and not transplant too late, being aware that we may still have problems after transplantation. With that, I come to my summary. As I said, ISH was a highlight regarding MPNs. The human actions was also very positive, although personally I was very skeptical due to the political developments. And it is, thank godness, in contrast to the political power shifts we are currently seeing. Thank you very much, and I look forward for the questions. Thank you. Yes, thank you a lot, Professor Al-Ali. That was very comprehensive and also promising. It gives us all hope that this range of possibilities is expanding. That is wonderful. I would now like to bring a few questions from the forum, and one question relates to diagnostics, which you also touched upon, that in your view all 3 driver mutations should in principle play a role in diagnostics and be tested. And now a member asks, how do I obtain testing for additional mutations? This addresses exactly that point, without this being at my own expense. Her oncologist told her it would cost money if we did that. With all due respect, yes, I know, I am familiar with this issue, and I must honestly say I cannot really understand it from some colleges, because today most laboratories already perform NGS. That means that data are already available in the laboratories, they just report what I think. Do you understand me? That means the cost for the laboratories with this NGS are the same. Therefore, as a patient, one should be aware of this. And I specifically looked again today in Oncopedia to see what exactly it says. Does it say sequential or does it say NGS? It says NGS. One can also refer to the guidelines, which we have just updated. I really checked again today. It is right, and it is state of the art in 2026. What does that mean concretely? So the patient has had an NGS test, and usually laboratories do this anyway, and as a patient one can then ask for to find this. As I said, the guideline clearly states NGS for driver mutations and no longer the sequential testing one after the other. But we physicians sometimes only tick. Do you understand me? Only CAR R or only JAG2, which makes no sense at all. A second group of questions revolves around the carotid studies. There is a question regarding participation in these studies, whether there is also the possibility that untreated patients can be enrolled. Yes, I can say yes. At the moment, there is actually a slot available. You know, with new therapies, we always start with the most severely ill patients and then move forward. And it is almost unprecedented that a phase 1 study has shown such good results in pre-treated patients that we are now already receiving slots for untreated patients. Yeah, that's good news. Absolutely. Another question regarding carotid cooling is whether there are observations that blasts in peripheral blood or bone marrow are eliminated or decreased through the antibodies. Yes, they do, as I said, because we see these changes in the bone marrow, but we still have to learn. It is a blockbuster, it is great, but we always have to wait and observe the course. But indeed, they disappear. I now have several patients. My experience is that we need 1 year of therapy in order to truly normalize fibrosis. And these stem cells, as I said, I showed you this example, and now I have several such patients, thank goodness, but all only after 1 year. That means I cannot expect that within 2 months I will have normal bone marrow and all blasts and mutations disappear. Clinically, it happens very quickly, within hours or days. That is the gratifying part, but all these mutations, the blasts, the fibrosis, that then regress very slowly. Yes, that sounds good. Another question in that context is an increased number of blasts an exclusion criteria for participation in the studies? Yes, up to 10% blasts in the blood are allowed. From 10% and above, it is an exclusion criteria. Then there is the follow-up question. Can the study be an alternative to stem cell transplantation? Oh yeah, difficult question. That is a very difficult and I think still too early question. If everything continues to develop as it currently appears, we might eventually, but it's still too early, really arrive at a situation similar to CML. You understand? As soon as we see a cortical limitation, hopefully also for JAK2 and MPL mutations, as soon as we see them, we give a specific therapy. We eliminate all stem cells, and in CML today almost no patient is transplanted anymore, but we're still a bit early. Nevertheless, it is promising. Yeah, very good. Now, another topic is being opened, namely bomedemstat. We did not see much about it in the slides. If I understood correctly, whether there are any new developments and when approval might be expected. Not yet, but it looks positive, especially in TE. At ASH, a small study was presented in polycythemia vera. Bomedemstat is an LSD1 inhibitor given as a tablet, relatively well tolerated. It is a challenge to adjust the individual dose correctly at the beginning. But in ET, especially in patients who do not respond to interferon and who do not respond to standard therapies, it is an extremely good option. And we have 2 phase 3 studies ongoing. First line to see whether bomedemstat is better than hydroxyurea, and second line That is the second study for patients who are pre-treated and do not respond. The required number of patients has already been reached, but they are still being followed. And we hope that perhaps next year we will have the phase 3 data. And if they are positive, approval can be expected. I personally have patients in both studies. I really do not find it bad, very good and very well tolerated. Another topic is fatigue. It is being addressed here whether there are new insights regarding treatment. The background is an ET patient on Pegasus treatment, and she asked whether combination therapy with ruxolitinib or LDN might be a promising approach. ET and ruxolitinib is a difficult issue because all the studies that have been conducted have not shown that ruxolitinib really does much regarding platelets. But for symptoms, yes. And honestly, this is how now a bit of inside information. The Austrians are very generous for ET or also MF patients. The combination of ruxolitinib with interferon. In Germany, we do this in such cases. If I have this problem, I have to submit an application to the health insurance because it must be covered. And the health insurance companies do cover it, by the way. Okay, so it could be a possible path, but somewhat difficult to implement. Not difficult. One has to submit an application, justify it well, and as I said, in Austria, colleges simply do it. They do not need an application and have a great deal with experience with this combination of interferon and ruxolitinib. Okay, now I am through with the forum questions. Ulrich wanted to cover the chat, which I see has been handled quite comprehensively. Ulrich, at the moment, or do you have anything else? You have to unmute yourself, we cannot hear you. I will just try to continue and perhaps we will have to pass the ball back and forth. Regner, the first question. I will go chronologically and summarize if I see duplicates. It was about interferon at the beginning, and the question is, why are such high interferon doses given? To achieve results more quickly, we always talk about quality of life for patients, and it would be much better to increase it slowly. I believe this referred to the ET rapid interferon stories where you mentioned doses. Correct, absolutely, fully agreed. But in the study, they started with 125 micrograms. From my perspective, that is also too high. Why do I have to start there? But my personal experience is that 125 is very well tolerated in most patients. But indeed, once it is approved, I would do it just as in PV, starting with 50 and increasing slowly, because it is a highly effective substance, and if I experience unpleasant side effects at the beginning, I naturally have no motivation to continue such a great therapy. And those were indeed my concerns at the beginning, but in a study you have to follow the protocol, and in my personal experience for most patients, I did not even need to increase further or could wait longer with increasing, because we can also wait a bit longer. By the way, the Asians, Hong Kong, they go up to 500 micrograms within 4 weeks in almost all patients. From my perspective, we do not need all that. And I am more a supporter of low and slow. That is funny because in introduction, before you joined, we talked about whether certain ethnic groups might react differently to medications. So perhaps they really tolerate interferon better and we can escalate that quickly. Well, I do not know whether 500 micrograms are tolerated so well. The problem is culturally, I would interpret it this way. Asians can play less. That is cultural. And I believe that is the reason, because if you look at the data closely, you see that the discontinuation rates are significantly higher than what we know here, and I do think it was a dosing issue. Okay, thank you. Next question. Well, will rusfertide be available in hematology practice, and will be it self-administered? These are injections, subcutaneous, assume. Yes, approval. The study data are now available. Takeda is preparing the approval process, so I could say end of 2026, beginning of 2027, it will be available. And then we have to be honest. Rusfertide is not necessarily needed for everyone. Even in the Middle Ages, people knew that phlebotomy is not something terrible, and it always depends. Do I have additional failure? How often do I need phlebotomies? Do I have iron deficiency? These are the factors that we will have to define precisely in daily practice after approval to determine which patients truly need rusfertide. From my personal experience, it will be about 1/4 to 1/3 of PV patients, because we know many patients, when we start interferon, no longer need phlebotomy. Then I do not need rusfertide either. One participant, you mentioned this at the beginning, when you discussed the antibody study that is so well tolerated, you said, what does it mean when patients are still in a study after 1 year? And I assume you are referring to compliance and tolerability. Exactly, because you know that always reflects tolerability and also the success of a study. And when I have over 90%, 94% in ET and 85% in myelofibrosis, heavily pretreated patients still in the study, and you know, it is no joke to receive an infusion every 2 weeks. And I have patients from all over Germany, and it is so impressive for me as well that no one wants to postpone therapy. Vacations are planned around the infusion their whole life, because as a patient you feel the benefit of this therapy, and it is really a wonderful thing. The company is also already working on extending the intervals to every 4 weeks after 1 year. If there is a good response, this is already something we discuss with individual patients today, and a subcutaneous injection is also being developed, so that one does not say, oh God, I have to get an infusion every 2 weeks for the rest of my life. Okay. All right. Then there was another question about the INSIGHT study, this carotidine antibody study. The question is, when will it move into phase 2? Is it not already in phase 3? No, it is phase 1 with an extension that is now already phase 2, and we are already preparing phase 3. It will start in about 6 months. This will be the approval studies. Honestly, based on this excellent data, I expected that the regulatory authorities would not even require a phase 3. Unfortunately, they insist on it, the American FDA as well as the European EMA. And it will be difficult to phase 3 to randomize refractory patients against a highly effective antibody versus best available therapy, and what is best available therapy for someone who is fully pretreated. You understand that will be really difficult. But my experience, it was the same with Gleevec in CML. They also had to do a phase 3. It was then stopped because it was no longer ethically justifiable when a highly effective substance is available. As I said, phase 3 will start this year, and if everything goes well, it could be approved in 2 to 3 years. Great. We keep our fingers crossed. You mentioned the specific JAK2 inhibitor, and there was a question. Will it also work for JAK2 exon 12? Exciting question. Yes, because the current data are mainly for exon 14. But why should it not work, since it targets the domain? It binds to the JAK2 domain. The study will also start in the second half of the year. All the regulatory steps are already underway. Very exciting. We have fewer PV patients with exon 13, and I hope it will work there as well as these patients can be included. Then I have a very specific question about antibody therapy in myelofibrosis with JAK2. After stem cell transplantation with relapse, so a complicated case, is this therapy suitable to reduce the allele burden and there be also increased chimerism again? You mean the calculating antibody, no? Yes. Theoretically, yes. However, currently allogeneic stem cell transplanted patients are not included in the studies. That means we do not yet have any data on this. But I repeat myself. At the beginning, I was skeptical myself and thought, what kind of antibody is this that selects which cell is mutated and leaves all other alone? But that is exactly what it does, and therefore one can well imagine that even after allogenic stem cell transplantation, since the diseased stem cells in the patient's own, the antibody actually docks onto those cells. However, we must wait until we have data. Then a general question, what determines whether a drug comes onto the market as an infusion or as a pill? That depends on absorption via the intestine. I have never seen antibodies as pills. Antibodies with their IgG or IgM structure and chemistry must be given as an infusion. On the other hand, tyrosine kinase inhibitors are well absorbed, are not destroyed in the intestine, and therefore can be given as pills or capsules. It depends on the bioavailability of the substance. Then again, a question about ET. Is bisremi preferable to Pegasus once it is approved? Difficult question. I say interferon is interferon. Overall, we know the experience from PV and they are comparable. It is simpler in terms of injection frequency. The side effects are well tolerated. I was the top recruiter in the study, have patients over 80 years old, and they are all doing great with the therapy, except for one young patient with severe headache case, where we had to stop, but I would not fundamentally prefer one over the other. Fewer injections is an argument, but basically interferon is interferon. Then a specific question. I am 49 and have pre-PMF and von Willebrand syndrome. Is treating with bisremi appropriate, or would you recommend another medication? Platelets, originally 1.4 million, currently 600,000. Yeah, bisremi is okay. I would recommend it because it is a biologic with the potential for disease modification. Therefore, in pre-PMF, without spleen symptoms, interferon would be a good choice. Then again, regarding the specific JAK inhibitors, yeah, it's a good choice. Then again, regarding the specific JAK inhibitors, do we already know at which centers the study will take place? I can only speak for myself, at my center for sure, but I am never the only center. Who else is involved? I do not know yet because the process is currently ongoing. When will the centers be finalized? In phase 1 studies, centers are selected by the sponsor. Usually one cannot even apply unless invited. When will the centers be finalized? Yeah, when will we know which centers? Usually one cannot even apply unless invited. Centers are selected by the sponsor. But at my side, all documents and contracts are already in progress. Yeah. For the antibody study, for example, we know that Aachen and Ulm, in addition to Halle, are involved. The V-specific antibody is also available in Hanover. One should inquire with the GSG-MPN to get an overview of study centers so that patients know where there are options close to home. Then, regarding interferon in PV, what is your experience with the duration until response, especially regarding hematocrit and the doses? Can it also take longer than 1 year? Very good point. Definitely yes. We increase slowly and do not use very high doses. I have seen several patients in whom it took over a year, where internally I had almost given up, who then achieved a complete hematologic remission with hematocrit under 45 and normal blood counts. It can really take more than a year. Okay, from when the criteria, and it's not, it helps not, we should have a lot of patience. Interferon is a slow-acting substance. I do not need to normalize everything overnight. You can also perform phlebotomy in between. I also have patients on combination therapy with interferon plus hydroxyurea. In my view, we stop more often than necessary. We should wait and have patience. And it's a pity that we stop a treatment that works so good. We must have patience together with the patient. Another questions are patients with an MPL mutation also participating in the studies? No, currently not. Then a question about aspirin dosing. Should heavier individuals receive a higher dose? No. We have a lot of data on 75 milligrams, which is standard in many countries. Here it is 100 milligrams, but there is no relation seen between BMI and the effect of aspirin. It should be the standard dose. Even with 50 milligrams, aspirin works well. That means even if I weigh twice as much, I manage well with 100 milligrams. Okay. Then in one of your lectures, you mentioned that allele burden under interferon can almost drop to 0, meaning the mutation is no longer detectable. Many physicians now face the question of how to proceed, continue expensive interferon injections, or stop. Is there a therapy recommendation? Very good question. Please no, do not stop. What we do, inject every 4 weeks, reduce the dose. I discuss it together with the patient, but I strongly advise against stopping interferon at the present time outside a controlled study, especially if there was a prior thrombosis. That is a major risk. I have a patient where I had to stop due to intolerance and liver toxicity. Within 3 months, and I monitored him monthly, the hematocrit was elevated again, and the JAK2 mutation was still at 2%. Therefore, I currently advised against stopping. Extend intervals to every 4 weeks, reduce the dose. Many patients are down at 250 micrograms every 4 weeks. That is a great success, and honestly, the economic aspect does not play a role for me in this context. Then questions about itching, pruritus. Are there new insights in persistent itching despite Jakabi for 18 months? Absolutely yes. That is exactly a point where one must say 18 months and still itching. I would consider combination with low-dose interferon. That is a sign that Jakavi is not working optimally for this patient. Normally, itching disappears under Jakavi within a short time. Now I have another question. I will see here. How often should blood counts be checked under interferon? It will adjust every 3 months. That is completely sufficient. At the beginning, every 4 weeks because of dosing and tolerability. Once the right dose is found, every 3 months. So I think we have all the questions answered. I'll see again. Yeah, I disappeared because I can see the chat. No. Let's wait. Let's see, we have 2 new questions. Is Berberami still an option if already treated for 11 years with hydroxyurea and then 4 years with ruxolitinib? Yes, absolutely. Interferon is approved both first and second line in ET and PV. Okay, now about question about JAK2 and TET2 mutations in combination. TET2, they are so specific also with the antibodies. No, not the TET2. It is not directly targeted. If TET2 is in the same stem cell as the driver mutation, I destroy the main driver mutation, and thereby automatically the other mutations disappear if they are in the same diseased stem cell. I showed this in a patient mutated carticulin plus TP53. Over time, TP53 also decreased. The antibody does not directly attack TP53, but the driver mutation. The other mutations disappear because they are in the same stem cell. But you said that TET2 with people with JAK2, they in studies with specific JAK inhibitors, it does not matter whether additional mutations like TET2, TP53, or other somatic mutations are present. Doesn't matter for the studies because one must differentiate between driver mutations. One must differentiate between driver mutations, JAK2, CARL, MPL, and additional somatic mutations such as TET2, TP53, ITH1, The decisive question is what drives the MPN? Yes, in the studies it is being they are so interesting. There's a lot of people with different combination of mutations, and to see, and they are not connected, but so for somatic mutation it works. Yes, in the studies it is being examined whether besides the driver mutation, other mutations also decrease. Okay, good. When is the right bisremi dose reached? If I tolerate it well and have good blood content. On average, in women, 100-150 micrograms, in men, more likely 150, sometimes up to 250. I generally never go higher than 250, initially possibly higher, then reduce again once values normalize. As a maintenance dose, most are at 100 or 150 micrograms. Amazing. Then I think we already answered all the questions. So, Rainer, you have a political question, right? Yeah, a little bit. Yeah, that's about the topic Asia. And I read that in both congresses of ASH, there were also results that were interesting, and they are usually from the west side of the world, and it's amazing. But in China, there are also interesting research results. Could these developments come to us? That's an amazing question. I do not know. In view of political developments, I consider it rather unlikely. We do not know their standards. They don't let us see. We don't know their standards. Do you understand? They present data quickly, but we cannot always verify them. And the question is, we can see them, for example, with the calculating antibodies with parallel studies, but in the Western world, studies run in parallel and control each other. If standards are not transparent, it becomes difficult. So it remains a big question mark. Yeah. I don't have anything else. Now I would ask, what are the most promising developments? Because I think that you could say something. Absolutely. Individualization of therapy. But so thank you very much for coming. I hope you enjoyed this free evening, and we hope that we can see each other soon. And thank you so much that you came here and that you had the time to come, and that you explained everything so detailed, and that you answered all the questions. And me and the listeners to thank you. We were 120 people in the call. There's a lot of people who are hearing you, and I hope that we will try to make a new webinar with you. And I wish you a pleasant evening, and until next time. And many thanks from my side as well. Thank you, all the best. Thank you. Thank you. Bye-bye. Bye-bye.